Welcome to the weekly Neurology Deep Dive. This program is produced by Amir Gavanini.
And before we begin our analysis of the clinical data today, we must clearly state that this deep dive is for educational purposes only.
Correct. It has no commercial goal. It serves strictly as a summary of the literature.
So we highly recommend that you read the full paper we discussed today to fully integrate these findings into your daily clinical practice.
Today, we are examining a paper titled Responsive Neurostimulation in Pediatric Drug-Resistant Epilepsy, a systematic review and meta-analysis of seizure and non-seizure outcomes, safety, and predictors of response. It is authored by Debo Pam Samantha and colleagues.
And for the busy clinical neurologist managing complex pediatric cases, you require the practical summary immediately.
So here is that practical summary. In pediatric patients with drug-resistant epilepsy, responsive neurostimulation provides a 50% or greater reduction in seizures for about 65% of patients.
However, complete seizure freedom rates are low, sitting at about 3%.
But the super responders, which are defined as those achieving a 90% or greater reduction in seizure frequency, they represent about 28% of the patient population.
We also found that longer follow-up significantly predicts seizure freedom.
Regarding safety, adverse events occur in about 16% of cases, and those originate predominantly from device-related wound infections.
Furthermore, quality of life and neurocognitive metrics remain stable, or they actually demonstrate notable improvement following implantation.
To properly contextualize those efficacy and safety metrics for clinical practice, you really need a precise understanding of the parameters defining this meta-analysis.
You do. So the researchers aggregated data across 39 distinct studies, which collectively encompass 413 pediatric patients.
And the inclusion criteria strictly required these patients to be 18 years of age or younger at the time of device implantation.
Exactly. Now, the median follow-up duration across that entire cohort is about 19 months.
But when evaluating the quality and structure of the existing literature, it's predominantly composed retrospective case series.
It is. The median cohort size is exceptionally small, at only 7 patients per study.
Just 7 patients per study. That is quite small.
Very small. And within this entire aggregation of literature, only a single study actually utilized a prospective design.
I mean, the patient profiles detailed in the paper represent an incredibly broad spectrum of clinical etiologies, too.
They do. The literature includes structural and lesional epilepsies, notably encompassing patients with tuberous sclerosis complex.
And the data also integrates highly complex genetic and infectious etiologies.
Right. The paper specifically details outcomes for patients with Dravet syndrome, Phelan-McDermid syndrome, Rasmussen's encephalitis, and febrile infection-related epilepsy syndrome.
From a purely statistical standpoint, that represents immense heterogeneity. You have varied epilepsy types spanning focal, generalized, and mixed syndromes.
Not to mention the significant variation in anatomical electrode placements across different institutions.
So how did the investigators structure their statistical models to account for these highly variable clinical inputs, without losing the resolution of the data?
Well, the researchers addressed that heterogeneity through a strict binary categorization methodology combined with mixed effects meta-regression.
Break that categorization down for the analysis of epilepsy types.
Seizures were grouped strictly into 2 categories. They were either focal or generalized.
So seizures reported in the literature as focal or multifocal were universally classified as focal.
Exactly. And conversely, generalized or mixed seizure types were classified as generalized.
The surgical lead targets would require a similar binary classification to maintain statistical integrity.
They did. Lead placements were categorized as thalamic if any electrode actively stimulated thalamic nuclei.
So this specific category included both pure thalamic configurations and corticothalamic configurations.
Correct. In contrast, the placement was categorized as cortical only if the stimulation involved strictly cortical leads with 0 thalamic involvement.
Following this categorization, the researchers utilized mixed effects meta-regression.
They used that to control for the baseline heterogeneity and to determine whether these distinct clinical variables significantly predicted the eventual treatment outcomes.
The exact findings of those efficacy outcomes present a compelling clinical picture for these drug-resistant pediatric populations.
They do. The pooled responder rate, again representing patients achieving a 50% or greater reduction in seizure frequency, sits at about 65%.
And the super responder rate, which tracks patients achieving a 90% or greater reduction, is about 28%.
Complete seizure freedom, as mentioned earlier, was achieved in about 3% of the pooled patient population.
So when you apply the mixed effects meta-regression to these outcomes, what specific clinical variables actually drive those response rates?
The meta-regression provided critical and, in some cases, unexpected data regarding the predictors of these clinical responses.
For instance, patient age at the time of implantation did not significantly predict treatment outcomes.
Furthermore, the proportion of patients presenting with generalized epilepsy did not significantly predict outcomes.
And the proportion of patients with thalamic lead placement did not significantly alter the overall seizure response rates either.
Which is vital. This specific lack of a negative association between generalized epilepsy and treatment efficacy provides robust statistical support.
Support for the application of thalamic responsive neurostimulation in complex conditions like developmental epileptic encephalopathies.
Exactly. However, the meta-regression revealed one highly crucial finding.
Longer follow-up duration emerged as the sole variable that significantly predicted higher rates of complete seizure freedom.
Yes.
Since the statistical analysis definitively shows that longer follow-up significantly predicts higher rates of complete seizure freedom, the study design itself requires close scrutiny.
It does.
Is a median follow-up of about 19 months systematically underestimating the true therapeutic ceiling of responsive neurostimulation in the pediatric population?
The electrophysiological evidence strongly suggests that 19 months is indeed an insufficient evaluation window.
So evaluating these patients at 19 months might be occurring too early in the treatment timeline to capture the maximum reduction in seizure frequency.
Precisely. The clinical data supports the necessity of extended follow-up periods, specifically due to the time-dependent neuroplastic effects inherent to chronic closed-loop stimulation.
Because direct intracranial recordings acquired from these devices demonstrate that immediate stimulation-triggered effects are not directly associated with long-term improved clinical outcomes.
Exactly. Things like immediate ictal inhibition or early frequency modulation of the epileptiform discharges do not tell the whole story.
So the actual clinical benefit derives from indirect, downstream neurophysiological effects that occur remote from the precise moment of triggered stimulation.
That is correct.
Explain the precise cellular and network-level mechanisms driving that long-term clinical benefit. If the immediate electrical disruption of an emerging seizure does not solely account for the 65% responder rate, what is happening within the cortical and thalamic networks over those extended months and years?
Well, chronic closed-loop stimulation establishes extracellular electrical field barriers between functionally interconnected epileptogenic neuronal populations.
So over extended periods of continuous monitoring and targeted stimulation, this chronic modulation actively isolates excitatory neuronal pools.
Yes, it isolates them from the core epileptogenic network. And this progressive isolation fundamentally alters the local network architecture.
How does it alter the architecture specifically?
It systematically reduces the amplitude and the power of baseline pathological oscillations within the neural tissue.
And by suppressing these dominant pathological oscillations, the chronic stimulation subsequently allows something else to take over.
Right, it allows higher frequency, desynchronized background activity to emerge within the network.
And this desynchronized electrophysiological state cannot easily sustain the hypersynchronous neuronal firing required for clinical seizure generation.
You have it perfectly. And because this time-dependent network reorganization relies on gradual neuroplastic changes rather than acute electrical suppression, you can see why an evaluation at 19 months captures only the preliminary phases of treatment efficacy.
The network requires significantly more time to achieve maximum desynchronization.
Exactly.
Balancing those profound long-term neuroplastic benefits against the physical reality of maintaining implanted hardware in a developing pediatric skull requires a very close examination of the safety profile.
It certainly does. The pooled adverse event rate across the 377 patients systematically evaluated for safety was about 16%.
For the clinical neurologist guiding a family through this surgical decision, that 16% requires precise stratification.
Device-related wound infections represent the most frequent surgical complication, occurring in about 4% of documented cases.
Crucially, these specific superficial and deep pocket infections constitute the leading cause of complete device explantation,
Which terminates the therapeutic intervention entirely. Hardware-related complications encompass a broader range of issues, though.
including electrical short circuits, primary generator failures, and the necessity for surgical lead repositioning due to migration or patient growth.
And depending on the specific institutional cohort analyzed, these hardware complications were observed at varying rates, ranging from 4 to 16%.
The paper also formally addresses mortality within this highly vulnerable patient population.
Yes, the literature reports 3 distinct deaths across the entire pooled cohort.
2 of these fatalities were instances of sudden unexpected death in epilepsy.
Notably, one of those instances of sudden unexpected death in epilepsy occurred in a patient who had successfully achieved complete seizure freedom following implantation.
And the third reported mortality involved a severe pulmonary illness occurring 1 year post-implantation, which the investigators deemed entirely unrelated to the neuromodulation device.
However, the systematic review explicitly highlights a critical surgical metric. There was 0 perioperative mortality reported across all 39 studies.
The complete absence of perioperative mortality really underscores the baseline safety of the surgical implantation itself.
It does. The ongoing clinical challenge is maintaining the long-term viability of the device within the pediatric patients.
So you must focus specific clinical attention on mitigating the device-related wound infections, as they represent the primary threat to the continuation of therapy.
Exactly.
Mitigating that 4% infection risk is paramount. What specific actionable protocols does the literature provide to help clinicians and surgical centers maintain the viability of the implant and prevent explantation in these pediatric populations?
The paper provides highly actionable, center-specific data addressing this exact surgical challenge. One specific high-volume center detailed in the literature successfully reduced their superficial pocket infection rates from a baseline of 19% down to 0.
From 19% down to 0. They achieved this dramatic reduction exclusively through strict, uncompromising protocol standardization.
Yes. The revised protocol required enhanced perioperative antibiotic prophylaxis.
It also required the implementation of significantly stricter sterile techniques during the entire surgical procedure.
And optimized, standardized post-operative wound care regimens.
This outcome definitively demonstrates that the primary complication leading to device explantation is not an inherent, unavoidable risk of the hardware.
No, it is a modifiable risk factor, highly amenable to targeted institutional quality improvement initiatives.
There is an additional critical safety caveat detailed in the review that is frequently omitted from broad pediatric neuromodulation discussions. We need to examine the prevalence and management of stimulation-related side effects.
Stimulation-related side effects are rarely systematically assessed or formally quantified in the existing retrospective literature.
However, when specific studies do actively track these metrics through detailed patient reporting, stimulation-related side effects occur in up to 50% of patients.
These effects primarily manifest as transient paresthesia and transient weakness, directly correlated with the delivery of the electrical stimulation.
So you must actively screen for these occurrences during follow-up programming sessions.
Because unrecognized stimulation effects often lead patients to limit their device utilization.
Or they lead clinicians to implement suboptimal parameter optimization, resulting in subsequent inadequate seizure control.
Fortunately, the data shows these side effects are almost universally reversible.
Complete resolution is typically achieved by adjusting the charge density,
Or switching the programming to a bipolar stimulation configuration, or even lowering the targeted stimulation frequencies.
shifting the focus toward the non-seizure outcomes, detailed in the meta-analysis, reveals a broader picture of therapeutic efficacy.
It does. The paper strongly emphasizes the clinical necessity of looking beyond strict seizure frequency metrics.
Because to accurately assess the holistic therapeutic benefit of responsive neurostimulation in a developing child, you must evaluate the impact on cognitive and developmental trajectories.
The researchers synthesized non-seizure outcome data from 12 specific reporting studies within the broader cohort.
Because the clinical assessment instruments varied significantly between different institutions, formal statistical pooled analysis was precluded.
Despite this limitation, though, the clinical signals across the reports remain highly consistent.
Quality of life metrics, behavioral assessments, and neurocognitive functioning were generally stable or demonstrated clear improvement across the evaluated patient populations.
Specific cognitive domains demonstrated highly notable improvements following the stabilization of the epileptic networks.
Patients exhibited statistically significant improvements in physical function, overall school performance, social functioning, and emotional regulation.
One highly detailed report within the review highlighted meaningful, objectively measured improvements, specifically in working memory and processing speed.
The paper also documents critical alterations in medication reliance following device implantation.
Several studies reported meaningful reductions in the overall anti-seizure medication burden for some patients.
And reducing the pharmacological load directly contributes to the cognitive improvements noted earlier.
Additional reports documented enhanced baseline alertness, significantly improved caregiver quality of life, and in specific pediatric cases, the acquisition of independent ambulation without the necessity of protective helmet use.
While these clinical signals present a highly optimistic trajectory for pediatric neurodevelopment, we must rigorously evaluate the methodological limitations and the statistical certainty of the evidence presented in this comprehensive meta-analysis.
The overall certainty of evidence for all primary efficacy and safety outcomes is rated very low according to the Grading of Recommendations Assessment Development and Evaluations Framework.
So you must interpret these promising results with appropriate clinical caution. The included studies universally lack prospective control groups.
The existing literature relies heavily on retrospective case series designs.
This inherent structural limitation thoroughly precludes definitive causal inferences regarding the exact magnitude of the treatment effects.
Furthermore, the systematic risk of bias assessment utilizing the risk of bias. In non-randomized studies of interventions, Tool rated 27 individual studies at a serious risk of bias and 9 studies at a critical risk of bias.
The predominant sources driving these high bias ratings were the complete absence of comparison groups and significant selective publication bias across the field.
Formal statistical analysis conducted by the researchers confirmed significant publication bias specifically regarding the responder outcome data.
Indicating that centers with less favorable surgical outcomes may be underreporting their pediatric data.
Yes, that is a significant structural limitation of the current literature.
Taking all the methodological limitations, safety profiles, and electrophysiological mechanisms into account, we provide the practical summary for your daily clinical practice.
Responsive neurostimulation yields a 50% or greater seizure reduction in about 65% of pediatric patients with drug-resistant epilepsy.
Super responders achieve a 90% or greater reduction in about 28% of documented cases.
Complete seizure freedom sits at about 3%, but it increases significantly with longer follow-up durations due to progressive network desynchronization.
The surgical safety profile is highly manageable, especially with the implementation of standardized institutional infection protocols to prevent device explantation.
We strongly remind you to read the full paper to explore the precise statistical nuances and the individual study methodologies driving these data points.
And before we conclude, we want to leave you with a final thought to consider.
As the field of pediatric neuromodulation advances rapidly toward adaptive responsive neurostimulation and utilizes state-specific targeting based on continuous EEG mapping, could future deep learning models identify the precise electrophysiological biomarkers of treatment response earlier in the therapeutic timeline?
Identifying those early would allow clinical neurologists to optimize stimulation parameters rapidly.
Thereby achieving a significantly faster time to network desynchronization and clinical efficacy during the critical time-sensitive pediatric neurodevelopmental window.